Okay, well, welcome everyone. We're glad you're all here. This is the second one this year for the ASGO ongoing quarterly webinar series, and we're glad you all joined us. Today, we will be talking about geriatric laryngology, interesting cases, and the panel needs no introduction, but let me do it anyways. We have Mike Johns from University of California, Caruso, Department of Otolaryngology. He's the director of the Voice Center there. Karen Kost, University of McGill, Montreal. Hylan Pickett, she's a speech language pathologist at the University of Arkansas for Medical Sciences. And Dr. Sataloff, he's a professor and chairman of the Department of Otolaryngology at Drexel University of College of Medicine. I'm Ozlem Tulunay. I'm at the University of Arkansas. And Alexander Chern, he's been moderating and putting this whole thing together for us. He's going to be also keeping track of all the questions in the chat. So if you want to add your questions there, and he's a PGY5 at Columbia, Weill Cornell in New York. So welcome to everyone. And we're going to keep it informal. Please, go ahead and put your questions into the chat as we're presenting so we can go ahead and answer them. And look forward to a nice discussion. Okay. And this is actually, most of you have already registered to be able to get CME. This is also in the chat box. It's how to register with Duke so you can actually obtain the CME. And if you've already registered, here is the code to text to the number there, so you can obtain your CME credits. And these are all in the chat box as well for you to be able to see through the meeting. So why are we talking about this? Because we are an aging society, world. People over 65 will outnumber children under the age of 5 for the first time in recorded history. And between 2006 and 2030, there will be doubling of people over the age of 65. Baby boomers are all, turning 65 and older now. People are living longer. We have better healthcare. So we are going to be seeing more and more of these patients in our clinics, and we need to know how to be able to help them. And dysphonia, while the reporting is not obviously great, is thought to be present in 12 to 65% of people over 65 years old. So while we're an aging society, we also have to keep working longer. And a third of the people 65 years and older still have to use their voice for work. So hoarseness is a significant quality of life problem. It also significantly affects their working abilities. It leads to social isolation. Anyone who deals with voice patients knows this very well. So it can lead to depression and anxiety. And also we know the literature shows that social isolation increases the risk for cognitive decline as well as Alzheimer's disease. And I'm going to jump into the first case. This is actually a video that I'm going to show done by Dr. Sataloff, and I think it's going to explain what this patient is going through beautifully, and then we'll go into the questions.
I have always been able to rely on my voice, depend on my voice. It's never let me down until a couple of years ago when it began to fail. I've lost many notes off the top range. I just can't reach notes. As a matter of fact, I actually had to cut a piece of the service out where I would have sung a solo piece because I just couldn't sing that piece of music.
Let's see what's going on. Yeah, your nose first. Better than the other, do you know?
Yes.
The examination we perform for patients with that kind of problem involves placing a little scope through the nose and another one through the mouth. Whistle Yankee Doodle. Yeah, that's a reasonable facsimile.
Vocal folds are supposed to close and touch, actually, like curtains in a theater or on a stage. My vocal folds did not close. The effect of that is like having a hole in the sail of a sailboat. It takes twice the wind to move the boat.
Deep breath. Say E again and keep it going when I suddenly let go. Relax. Do you hear the difference in the strength when we bring your vocal folds close together? Do you hear it get breathy when I let go?
Yes. Blind mice. Three blind mice. Three. So Dr. Sataloff then prescribed for me a period of therapy to see if the voice therapists could get those vocal folds to close without surgery.
Now, I want you to try the same thing again. Comfortable?
Yeah.
It's sort of like physical therapy for the voice. It involves exercises and training of the speaking voice, and that includes training the muscles of the abdomen and back, the way one uses lungs in order to use the voice efficiently. We have also used singing training.
Yes, sir.
As it turned out, after a month and a half, perhaps 2 months of therapy, it became evident to them that therapy alone was not going to solve the problem.
I think in the long run, we're going to end up bringing your vocal folds close together.
Surgically.
So the question is whether you want to just see if you can prove me wrong and give it another month with the voice team. I'll tell you what I think we should do. I think we should schedule you for surgery in about 6 weeks. Let you work with the voice team. I'll see you again in another 4 or 5 weeks. And if you're making real good progress, we'll cancel. Now let's see if this makes you better or worse. Do it again.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So this is the first time you've spoken since then?
Yeah, I've been on complete voice rest since, so I didn't even know what would come out of my mouth today.
Well, let's do this. Let's go 1, 2, 3, 4, 5. Speak up for me. Start low and ascend.
Yeah, help me set boundaries, because I am a little anxious about overusing.
Just, you know what? Joanna will do that for you.
Okay.
I'm just going to check the range right now.
1, 2, 3, 4, 5.
Yeah, don't force it down.
The voice therapy is critical following the surgery, because the surgery hands you the toolbox again. The voice therapist teaches you how to use the tools again.
People's recovery from this surgery varies a lot. Many of our patients have no swelling and their voices are normal at the end of surgery, and they're still normal a week later. Mr. Mann took a little while to recover, but he has gotten better and better and is continuing to get better.
Not because it's pretty, but because it says something to us that we long to hear, that no matter who we are or what we are, there is still one person who will come in and sit down next to us and be with us just the way we are. I did the whole service today. It's the first time I've been able to do a service all by myself in a long, long time. This is my story, this is my song, praising my Savior all the day long. This is I can rely on my voice now. I mean, I use my voice professionally, so not to have my voice means that I would not be able to do my job. And in a real sense, I feel like Dr. Sataloff has given that back to me.
Change my heart, oh God, may I be like you. There is very little that is more fun than taking somebody like Mr. Man, who is struggling just to get by, working with him, operating on him when necessary, and then working with him again. And then seeing him go back to his life with his old spark, his old verve, and most of his old voice. May I be like
I think there can't be a better video that summarizes why it is so important to treat these patients. So I had some questions about this, and Hylan, are you there?
I am.
Yeah, maybe let's start with, what are your preferences in terms of voice therapy for these patients?
So for the, go ahead.
Yeah, how do you work with them? What do you focus on?
Sure. So the professional voice users, especially when, we have a glottic gap and they aren't able to get the vocal stamina, not to mention, the range, the quality they want. I begin making sure that there's not any initial hyperfunction or poor compensations for that by doing some airflow phonation, just to kind of rule those things out and make sure breath support is looking good. 9 times out of 10, breath support is not ideal. And so we, do some hands-on adjusting posture, some tactile cues for breathing, and re-coordinate the diaphragmatic breathing. But then I move into things like vocal function exercises, Joe Stemple's exercises, where we have glides with forward resonance, full range and back down, and then them being able to sustain that and use perfect breath control with, the sustained forward resonant buzz. Sometimes we'll do lip trills, buzzes, things like that to help them, not poorly compensate, but to get that up and forward. And then working that into speaking voice, we're still using resonant techniques so that they are able to, lift, compensate that voice without having to press and force everything, and then fatigue a lot faster. So.
Thank you. And anything else to add from our panel members?
Sure, if I may.
Yes, please.
Hylan did that summary very nicely. I appreciate how succinct that was. She mentioned in passing breath support. Many of these patients are not in great aerobic condition. Some of our younger ones aren't either, but especially this population. So if we expect them to have good breath support and they can't walk up a flight of stairs without stopping twice to catch their breath, and they can't do a sit-up or a crunch, we can't expect them to have very good support for their voices. So we often include medically supervised general exercise and aerobic reconditioning. The other issue, we do voice therapy first for all patients, but the duration varies. The general paradigm is we keep them in voice therapy until they plateau. And then if they are happy and good enough, they're done. And if not, we go the next step. But in the geriatric population, we have to take cognition into account. And if they do a couple of voice therapy sessions and when they come back for the second one, they don't remember having been at the first one, let alone what they were supposed to be doing in between, then we don't keep them in voice therapy for 6 months. It just frustrates the patient and the voice therapist. We proceed with surgery earlier in this population rather than later, which is a little counterintuitive for frail patients, but it is a huge quality of life issue. It can be an aspiration and cough efficiency issue. And we have to remember that while their voices are getting soft and strained, all of their friends are going deaf. So these people need help one way or another, and the therapy is we always try it first, but it has to be individualized. We also do singing voice therapy not therapy, singing voice training with everybody, singer and non-singer. And we explained that by saying if you had trouble walking and we sent you out walking, it'd take 6 months. If you could jog and run, your walking muscles would get strong in 6 weeks. And the singing voice therapist and the speech language pathologist work in the same office next door to each other. Actually, all 3 of our speech language pathologists are singing voice specialists and trained singers. That combination can be very effective with this patient population if they're cognitively able to participate.
And same for us, Hylan is also a singing therapist. And yes, I think there's significant role, especially in Parkinson's disease. I think there's a lot of reports coming out about the importance of singing therapy and group therapy, even with singing. So that was one of my questions. Does everyone try to do singing therapy, Mike?
So just not specifically addressing that, I certainly think there's value there. And mostly it comes down to voice use and dynamic voice use and using your voice. And I just wanted to make the point that it's important for me to make sure my patients understand what's going on with their voice. And what I presume we're talking about here, even though we haven't mentioned the specific diagnosis, is age-related voice changes and vocal atrophy as a component of it, but obviously not the whole picture. And I think it's really important for us to convey to our patients, here's what's going on, and here's how you power it up and rehabilitate, just like any athletic or physical task. And whether that's via singing or structured therapy or just using your voice more, these are folks who don't get themselves injured by voice use typically. And so I think that's an important starting point. I can't tell you how many folks I've seen who come and who are this very similar presentation, have been seen by other folks, and they don't really have a sense of what's happening. And so we've got to like bring it back a step or two so they can be empowered to take the steps they need. Because this is something that really has an internal locus of control more than an external locus of control if we're going to start talking about injection, augmentation, or procedures for this.
I agree with that 100%. And we'll add 2 comments. Number 1, hopefully you noticed on the video that much of the explanation of what was going on was given by the patient.
Mm-hmm.
We think that that's extremely important. If the patient isn't educated well enough to be able to explain to somebody else the problem of glottic insufficiency and what's going on, then we have not done our job. And as far as I'm concerned, their consent isn't fully informed. So I agree 100% with Mike. Second, people get into trouble with hypofunctional voice problems through hyperfunctional compensation, trying to be heard. And it's a big help to the speech pathologists when we explain to them that when their hyperfunctional compensation is unloaded, they are likely to sound worse to themselves before they sound better. And that's a normal part of the process. Because if we don't, they go in, they do what the therapist says, their voice gets soft and maybe a little tremulous, and they don't come back because they think the therapy is making them worse. They don't understand that they're working around muscles that they should be working unless we tell them up front.
I completely agree, Dr. Sataloff, and that's part of my education portion, is to, help them understand the anatomy and physiology so they can be motivated to do the exercises that may seem silly to them, and whether or not they're aware of how their change is sounding with their voice. But it makes all the difference for them to know the reason and what is going on at that level to keep moving forward.
And I think one of the things we mentioned, elderly patients do have different requirements. Like for us, we're the only university center in Arkansas, so they come from far, and they usually rely on people. So we may cut the therapy shorter than we would for a younger patient and go for procedures. But also we've been using a significant amount of telemedicine. I think that's the one good thing that came out of COVID. So, that's an option now at this point. Chern, do you ever do any temporary augmentation before you go for permanent, maybe thyroplasty type procedures?
Yeah, I just wanted to make a comment on the first question, and then I'll go to the second one. So I agree with everything that's been said. I will say that I have noticed, and it's interesting because we don't really have good studies comparing the value of injecting first versus voice therapy first versus definitive surgery first. However, yes, they all go to voice therapy, but when I see a patient who's got a big glottic gap, my experience is that voice therapy alone is rarely enough. And in those patients, I don't regularly put them through 6 weeks or 8 weeks or 12 weeks of voice therapy before doing something. I just tell them, listen, this is a big gap. I don't think that you're going to improve enough with just voice therapy. Why don't we inject you today and have you do some voice therapy with the injection in place? And I think that can often be a very useful maneuver. I use a lot of temporary augmentation, and that might be partly because of the system I work in, where it takes a while to get patients to the operating room. So I will start with an injection, and they see the benefit and then move on to something more permanent. And I think it's useful also in helping the patient understand the changes, the positive changes that they can get from an injection while they're waiting for something more permanent.
Karen,
Right.
what do you inject? And do you do it in the office and through a working channel or transoral, or how?
So I personally don't like, I don't use anything except hyaluronic acid. So I don't use CAHA. I don't like it. I've never really liked working with it. And it's very unforgiving. And I work with residents, and I think that's important. So I use hyaluronic acid. That's kind of my go-to. And I know that it's going to disappear in a few months. So while they're waiting for surgery, this I think is a useful maneuver, and I do it all in the office. Now, of course, even though there's some publications, one in particular that looked at injecting patients on anticoagulation, where they found no increase in bleeding in these patients, even patients on Coumadin. I personally will not inject a patient who's on Coumadin or some other anticoagulant unless they stop it or are bridged, with the exception, of course, of aspirin. I don't think that makes a difference. But if they're not on any anticoagulation, I'll just, yes, I do it in the office. My go-to method is often cricothyroid, but I'm very comfortable doing a thyroid injection if I need to. And we do have needles now that go through the channels of our scopes. So that can be used as well, although you lose an awful lot of the product just in the length of the channel getting to the vocal fold. So it depends on the patient anatomy, essentially, but probably our number one technique is cricothyroid.
Mike?
So I think it's super important to educate our patients again about what we're doing when we're moving on from what I think is a dynamic rehabilitative approach, i.e. via voice therapy and its kin, to what is a static geometric solution to a dynamic problem, which is injection augmentation or bilateral thyroplasty, where we're mashing the equipment together. And so I always do a trial injection first. Reason is that we're adding mass to the vocal folds. The patient's work of phoning sometime is increased. We don't have complete clarity on what the pathology is, oftentimes, whether it's body volume loss or vocal fold mucosal layer thickness. And so I always do a trial injection augmentation. It is certainly accessible now in the office, which really has changed kind of how we treat these folks. But I'm pretty straight up with my patients that, this is a geometric solution, and don't think that, now I'm the magic and you're going to be, singing at will afterwards. So caution.
I love this because we approach things differently. And I didn't know how differently until tonight. I very rarely use a temporary trial injection. I only use it when I'm really unsure of the problem. I'll use it, for example, in people with bilateral vocal fold paralysis who've had a rytenoidectomy and need a slightly better voice. And I want to see what happens to their airway when I bring their vocal folds closer together before I do a thyroplasty. But in these patients, I almost never do. I agree with Karen about not keeping people in therapy forever when you see a huge glottic gap. So in that population, I'll schedule them for surgery within a month or 6 weeks, put them in voice therapy enough that their post-operative voice therapy has been done preoperatively and they know what they're doing, and then take them to the operating room. If they have enough atrophy, I will often start with fat injections with their understanding that they are likely to need a repeat fat injection or a thyroplasty later. But if they're really badly atrophied, like one of the videos we're going to see later, I like to have something like fat between the inside world and the thyroplasty implant. Often the fat's enough. When it's not enough, I feel a lot safer putting a foreign body in with a nice thick layer of fat. But with a temporary implant, we don't have any delays, Karen, in getting people to the operating room. The only delay is my surgical schedule. What I don't like about the temporary augmentations is that you have to really wait until you're sure it's gone before you do a thyroplasty with them, awake and fine-tune the voice. And in our setting where there's not really any delay time caused by the hospital, the temporary augmentation, if you use Restylane, hyaluronic acid, as opposed to saline, can add 6 weeks or a substantial amount more than that before we can do the definitive procedure. So I think both approaches are absolutely correct, but we definitely manage things differently among those of us. Ozlem, how about you?
I think I'm in between. I do use temporary injections more often than you, especially in patients who have poor breath support. They do some therapy, they don't improve. I really have in my mind, would even augmentation help them, because they're such poor breath support. I use it for them to kind of make sure that I'm not putting them through like a 3-hour surgery. If it's not, I use it in most of my Parkinson's patients before I augment them, but I probably use it not as often as Mike, but quite a bit. And some of them I'll take to the OR if I just want to examine the cords closer and do it in the OR. Otherwise, I'll do it in clinic. But yeah, it's nice that we're all doing it differently. I think that's the beauty of these panels. And then is there anyone who uses silicone, or is everyone doing Gore-Tex for bilateral augmentation?
Are you talking about silastic implants?
Yes.
Yeah. So I definitely prefer silastic implants to Gore-Tex. I've used them both. I've got somebody that works with me who uses primarily Gore-Tex, and I think initially it gives a very good result. I have seen in a number of these cases, I've done a few revisions on these patients, where with time, it seems that the Gore-Tex, I don't know if it settles or something changes, and it seems to be a little bit less effective. Whereas I find that silastic is pretty stable over time. So I will use silastic, but I just want to step back a little bit and say that I really like fat in these patients. Bob mentioned this already. And it is true that you sometimes have to re-inject fat after a year or a year and a half, but I really like it as a material. It's supple, and I just find it really gives a very, very nice result. And I want to make one other comment on something that you mentioned, Ozlem, which is breath support. I think the single most important predictor of success, all other things being equal, is the patient's lung capacity and the status of their lungs. So if they really have incapacitating lung disease, I think at some point it doesn't really matter what you do. You're not going to be able to have a significant improvement. And there is some data to show that severe pulmonary disease can be a big limiting factor in these patients.
Mike?
Dr. Kost brings up so many good points there. I'm a scholastic person. I'm a fan for immobile vocal folds, and it's just locked, it's loaded, it's stable. What you got in the OR is what you're going to get 3 months later. So get it right the first time. So that's one thing I like about it. For bilateral procedures, I tend to use Gore-Tex because of the ability to adjust both sides simultaneously without generating lots of edema of popping implants in and out. So I tend to use Gore-Tex for atrophy, and they typically don't need a lot of medialization for the most part. But you bring up a really important point, Dr. Kost, and that is that injection augmentation is not the same thing as thyroplasty for medialization. We get volume expansion with injection augmentation, and fat really does have those properties that you talked about, that we really like. The downside, of course, being the morbidity of the harvest and general anesthesia. And if we had a way to do that in the office easily, that would be a game changer, in my opinion, something that was durable. There's a product we're studying right now in a clinical trial called Renewava, which is it's a decellularized fat matrix that, of course, holds the quote unquote promise of having new fat grow in and whatnot, the story we've heard from other injectables over the years. But there may be some promise there to take away the morbidity of the harvest. But I'm with you, Dr. Kost, because big volume expansion is kind of what is needed more than a push from outside to in. But we haven't talked about the lamina propria yet. I bet.
Yes, and actually, I think I'm going to skip these few questions and see if we have any time at the end, but do our second case, because I think it will, help with our current discussion as well. So,
Ozlem,
all right, Dr. Sataloff.
I can't let it go. Hey, I'll cut down all the things I was going to comment on, but I use a lot more Gore-Tex than you all do in mobile vocal folds. And there is a technical trick to using Gore-Tex that not everybody does, Karen, and you might talk with your colleague. When you implant Gore-Tex, you have to take either a Woodson or the Sataloff thyroplasty instrument and firmly pack the Gore-Tex laterally against the cartilage. If you leave air loops in the Gore-Tex, which are always there when you insert Gore-Tex strips, then as fibrosis occurs, the Gore-Tex will become compacted and shift. If the Gore-Tex is compacted by the surgeon and the air loops are all missing, then you get a stable long-term result. And since these vocal folds are mobile and they're bowed toward the center, I find it easier to shape Gore-Tex than I do to shape the silastic blocks. That's number one. Number two, for the last 4+ years, we're writing it up now, I have been using implants of homographed fascia lata sheets, not injectables. And my initial results have been very favorable and very interesting for small glottic gaps. I have nothing negative to say about FAT having co-authored the original paper. I like it, I use it a lot, but it has some unpredictabilities for non-paralysis patients who are looking for optimal voice, not just within the normal range. About a third end up having something else done, either another fat injection or thyroplasty. And I don't think that that's a reason not to use it, but it's something to consider depending on the patient and the degree of vocal fold atrophy. So sorry, Ozlem.
No, sorry. Yeah, you're using the fascial lata rather than the Gore-Tex, not as an injector. You're using.
Oh, correct. For people with very small glottic gaps, it has several advantages. I do it endoscopically. You make a very small incision lateral to the vocalis muscle, create an access tunnel, and insert the Gore-Tex. And if the incision stays small enough, you don't even have to put in a suture. One of the big advantages is that if you have to remove a vocal fold mass that somebody's gotten hyperfunctioning to compensate for glottic insufficiency, I don't like to do a microflap and resect a mass and then do fat, because you have to over inject and you end up spreading out your incision and making it big. But you can implant fascia at the same time and save a second procedure. That's why I started using it. Morselizing fascia has been reported for a long time, especially in Scandinavia. It's a pain in the neck. I don't think it holds up very well. If you don't have the patience to morselize it in tiny pieces, which I don't, I have actually broken a pruning syringe trying to force the fascia through with autologous fascia. I use the same homograph fascia that I use in my otology life for tympanic membrane replacement. I've used it for 30 or 40 years. And it works pretty well if the glottic gap is small. And you can do both sides at the same time because you're nowhere near the edge.
We look forward to the publication. I think that's going to be very important. Our second patient is a 75-year-old man with long-standing history of roughness to his voice, which he attributes to singing above his range, as a child. More recently, he had gradual loss of volume, increased breathiness, and increased effort to speak. He prefers to whisper because of these, but he can phonate with effort. He is using steroid inhalers. He's a non-smoker. He has no other complaints, and he has history of cardiac surgeries. Here's his voice.
The rainbow is a division of white light into many beautiful colors. They take the shape of a long arch with its path high above his two ends, apparently beyond the
Keep using your voice
The blue spot is on the key again.
as much as you can. Use your voice again.
We dance every Easter when Mama makes lemon muffins.
And then here's the scope.
Puff up your cheeks like you're blowing a balloon. Good. Okay, relax. Now you're gonna sniff in through your nose. Good. Now you're gonna say E in between. So like this. E, E, E.
E.
Good. And breathe in. I want you to breathe in between. So E, E, E. Good. Faster. One more time. One more time. Good. Okay. Now low to high. E. Good. A little bit lower. E. Good. And try to get louder. E. Good. Now take a big breath and hold out aloud. E. Good. Can you do that again, louder? Okay, one more time.
So I'll move on. So Hylan, what would your approach be for this patient?
So I would do a trial for 1 week of Lee Silverman voice treatment. to see if he could sustain, any type of connected speech with more effort. And then I would spend some time with diaphragmatic breathing. I have a feeling his posture is not good, not having seen him, but to really work on, his anchor, making sure that he can have tactile cues to feel deeper breaths. But, then I would ask, is this exhausting? Can you sustain this for even the length of a conversation or longer? Because most of the time, those patients say that their vocal stamina is just very short, even though they are speaking in short phrases with that max effort, they just can't sustain it for long periods. So if we didn't get anywhere or improve significantly in that first week, then I would be deferring back to laryngology and saying, I think it's time for us to consider injections or thyroplasty.
Mike?
Hylan, thank you for those observations. That was the initial approach that we took. This to the record, this is my case, a patient whom I saw, and there's quite striking findings that you see on this video. If I could just describe them, there's no supraglottal or hypopharyngeal masses. Motion seems to be pretty full and symmetrical bilaterally. The laryngeal mucosa appears healthy, but there is a huge glottal gap, very prominent vocal processes, clear evidence of age-related changes to the body, but also, and maybe most pronounced, bilateral loss of lamina propria. So it's important that we start with the diagnosis, of course, of the various elements that contribute to dysphonia in the aging population. And this patient has vocal atrophy and bilateral significant vibratory surface loss, or they call that sulcus vocalis, or whatever lingo we want to use around that. But he whispers because the effort is low, but he can generate some sound. And so that's why I really appreciate the short leash therapy, if you will, to see kind of what someone who's decided they're just not going to talk can do as a first approach. So this is a fresh case, so we don't know. This is what's happening. I believe my SLP colleagues and peers who are on the call are probably taking care of this guy in the next couple of weeks, and so we won't be able to report back, but I'm presuming he's going to need something else. I'd love to know what people's thoughts are.
Karen, what would you like to add?
Well, I think Mike brought up some really good points, and that is that, even with really expert voice therapy, singing therapy, by all our dedicated speech language pathologists, his gap is so enormous with this superimposed problem of a sulcus that it really is not going to be enough. And this is obviously a difficult problem. I would have a serious discussion with the patient about what his goals are and about realistic expectations. I don't think we're going to turn him into an opera singer. I think that one of the points that Dr. Johns brought up, which is extremely important and we haven't really discussed, is the superficial layer of the lamina propria and some of the changes that occur there with aging. And we know that there are many changes that occur at that level. And so all of our rehabilitative methods that are surgical at the moment are primarily aimed at restoring bulk, but don't address this. And Hirano looked at it. I think the future ultimately will be in bioengineered scaffolds that can help regenerate the superficial layer of the lamina propria. It's not quite there yet in terms of prime time. I think that in this patient, my first goal would be to address the gap. And so in this patient, I would favor fat. I would do a bilateral fat injection and see what kind of a result I could get with that and with some voice therapy and go from there. But that would be my first step.
Dr. Sataloff?
very interesting case with lots of opportunities for debate. First of all, Mike, I agree with your reading completely, and Karen, with your approach. One of the striking things about this video is that there isn't more supraglottic hyperfunctional compensation. That raises concerns about whether this person is frail, whether he has sufficient pulmonary function to undergo general anesthesia and do things that we would want to do safely. We do pulmonary function testing on 100% of new voice patients, regardless of age. So, I agree that all other things being equal, fat is a good first approach. I would do that too. But I would be real sure that we're not going to decompensate his respiratory ability by giving him better closure. You usually don't, usually make it better, but it's a concern. Second, you can do a full injection on one side, which is 40% over injection if you can get it without having it extrude, and a little on the other side, maybe a 10 or 15% over injection. But I always tell these people that their fat injections are going to be staged, and usually they are. If you do a full 40% over injection on both sides, even people with good lungs will occasionally run into airway trouble, even though they shouldn't, because the cartilaginous portion is open. So I'll tell them staged, put a little bit on the second side, but not attempt to get a full injection on the second side, and plan to do it as staged procedures. Now, this is an old person. The first thing I would want to do is medial compression of the thyroid cartilage, as you saw with Mr. Mann in the video. The problem is many people this age have such calcified thyroid cartilages that you can't get a good assessment. I think that this is such an obvious large gap that I wouldn't do a temporary injection here. But the last thing is, Mike, I agree with you about the loss of superficial lamina propria. The question is whether it's symptomatic and whether the symptoms are significant for this person. It's so hard to assess that with no glottic closure that I agree with Karen. I would medialize first, get the vocal folds so that they approximate and oscillate, and then see if it's really necessary to do anything for the lamina propria. And if it is, we have some things, but Karen's right, regenerative medicine is the answer, and we're not quite there yet.
And I like fat for this because it covers for lamina propria loss, because at least it's soft. Like implants here are just going to squash thin atrophic tissue together, and you're going to trade breathiness for roughness or aphonia. Our HA injections or gel or whatnot would likely do the same in my experience. But we did, Hylan, taking your approach first, to power him up a little bit, because if you just whisper in there and you're not putting the good do in, then you can do whatever. We could pierce this vocal fold with a diamond and he's still going to whisper. So yeah, so stay tuned on this one.
So I guess, I mean, we answered already some of these questions. So it seems most of us is preferring to do the augmentation first before looking into anything for the sulcus or the lamina propria loss. Am I right on that?
Ozlem, it should be mentioned that there are two ways to use fat. So far, we've been talking about fat injection. If there really is true type 3 sulcus with the epithelium stuck to the vocal ligament, then fat implantation is a good potential approach, but that's a completely different procedure to be done one side at a time at a different time. But it wouldn't surprise me if this person were happy with his voice if he were just able to get his vocal folds together.
These are the challenges. We don't have good treatment for the mucosal layer of the vocal folds, and especially things that don't have a fairly high barrier to entry for someone who's like super frail, like this guy, who is, probably not even a candidate to be put under general anesthesia. And this is why we're trying to look into some of the regenerative elements that are accessible to us now, a la Shigeru Hirano with his beta fibroblast growth factor injections. We've been trialing PRP in a clinical trial, and maybe there's some possibilities there, but this is the frontier. We see this in some of our patients who get an upper respiratory tract infection and their voice gets better, our atrophic patients, and the lamina propria presumably expands and presumably get better vibratory capacity, and paradoxically.
I've done some work with AmnioFix, which is a growth factor, and it's off the market. And there's another one, and I just blanked on the name, but there is another one. It's got a slightly different proportion of hepatocyte growth factor and fibroblasts. It's a little different from the AmnioFix, but it's available and it works for scar, which is a little different from this. I've been using for the last 5 years 5-fluorouracil, and that paper is in progress now too. For the 5-fluorouracil failures, the AmnioFix has actually had some results and saved a couple people that I thought I was going to have to do fat implantation or buccal grafting on. So I agree with you. We need to look at Shigeru's work, but there are things on the market that are available and usable.
And we need to capture them, study them appropriately, and communicate well, because there's not going to be big dollar funding for this, because there's just not a lot of research dollars that are going to care about this man speaking again, to be honest.
And I think this unfortunately has been a slow field, because I know Chetri was even working on fibroblast growth factors, like, I don't know, 15 years ago now, on sulcus patients. And I think nothing has materialized, but that is going to be the future. I agree, scaffolds and tissue engineering. So anything else you would like to add on this one? Otherwise, I would like to talk briefly about tremor, because I think there is an interesting issue there that we deal with as well. This is actually a very typical vocal tremor patient. And I think my experience has been, I send most of these patients to neurology to ensure there's nothing underlying, and in the hopes that they might try some medications, but they all come back to me from neurology saying, just start Botox injections. So first of all, is there any role for voice therapy? Hylan?
So I do see a lot of variable outcomes for this diagnosis. And so the time that I do see better outcomes is when there's some significant hyperfunction overlying, at secondary to the tremor. These patients tend to have breath holding patterns. And so a lot of times I'll do a little bit of airflow phonation and help them, relax the false folds and, improve their breath support as a result, and help them realize that they can get a more, full voice without that stopping and cutting off their phonation. But I will say with, if they can't do shortened phrases and compensate using their breath support, then typically, if they're not stimulable, within 3 to 4 sessions, I send them back your direction for possible Botox. But I give them the chance, because sometimes they surprise me and end up with some good results after going home, doing the home program, and coming back with the airflow phonation techniques.
Would anyone else like to comment on the therapy? Yes, please, Dr. Sataloff.
Just on the therapy?
Well, to start with, I have a lot of questions. I think we can probably go over just a little bit. It's a nice discussion, so if people don't mind staying, I think we will be okay staying. So.
Okay, as long as the Zoom link doesn't turn off. And even if it does, we can keep talking. Almost all of the tremors that we deal with get worse with effort. You see that in hand tremor, you see it in everything else. And you certainly see it in voice tremor. When they try to get loud enough to be heard, their tremors get worse. So eliminating hyperfunction, and I'm all for early medialization, that makes it easier for them to be heard without increasing effort and making the tremor worse. This is an interest for us. We just started an interdisciplinary voice tremor center with neurology and neurosurgery. In the 80s, I think our group published the first paper on deep brain stimulation for essential tremor. Jim Gould was going to send Katharine Hepburn down, and she ended up in a nursing home and never made it. That would have helped these people a lot. But I can tell you the only thing that really works for people who have bad tremor is deep brain stimulation. The voice center is very close to the hand center. And if you have people who have had deep brain stimulators placed for hand tremor, you can often juice the settings up a little bit and get spillover into the voice. But I have not had spectacular results with Botox. You can make people a little better, but you can also have it end up in the wrong place and get them aspirating. And this is usually a pretty fragile group. I've almost stopped using Botox for these. We use propranolol and Topamax and other things, medialization, and if they're bothered enough, deep brain stimulation, a neurosurgical procedure that can be done without general anesthesia. It can be done with the patient's awake, and you can turn the stimulator off and the tremor comes back, and you turn it on and the tremor is gone. So the people who are not scared away by the notion of anything neurosurgical actually can be pretty much cured.
Mike?
So, vocal tremors, complex central neurological disorder involving the whole vocal tract. And I agree with Bob that the targets are going to be central, of course. And we're certainly seeing some promising results with DBS for some folks. But certainly in terms of what we have available to us for our patients who generally on first or second pass aren't super enthused about a neurosurgical procedure. I mean, we're talking voice therapy, meds, or Botox, or injection augmentation. And I think there's a lot to be gained, Hylan, through a short course of voice therapy, at least in terms of the understanding, at least about how the voice works. And I think people can understand about what their impairment is and can help inform them with how far they want to go with procedural elements. Medical therapy, obviously less effective for axial tremors compared to peripheral tremors in the hand, but it's worth a trial. Some patients respond, and if neurology access is limited, I'm willing to prescribe propranolol myself. I tend to leave primidone and the other ones to the neurologist. Botox, for patients with glottal stops, we can effectively eliminate them with artistic titration of Botox to them. To go to e. Okay, it's not a perfect fix, but can help with effort and sort of vocal fluency. And then augmentation, of course, all of this is overlaid on the phenomenon of atrophy. These are older patients. And so we know these are intention-induced activities to a certain extent. So the role of augmentation makes sense to me to a certain extent. And so I try to make a judgment with the patient about, are we dealing with more of a problem of breathiness and effort versus kind of spasms and abnormal movements, and titrate augmentation versus Botox, sort of based on that. So that's my 2 cents.
When you can't figure that out, this is one of the populations where I think there's a pretty common place for trial temporary injections.
Totally. Yep, exactly. Spin the laryngology therapeutic wheel, and most of the stuff we have doesn't hurt.
Karen?
Well, these guys mostly stole my thunder, but I think it's mostly been said. But just to rephrase, I do think that a couple of points. One is that I think hypophonia is a real issue in a lot of these patients. And so for this reason, I use Botox very judiciously, but never first. I always do try voice therapy. I think there's a role for it. I think they can have some coping strategies, and injection augmentation, I think, is very useful to at least correct the hypophonia. I've had a couple of patients who are very happy with that and tell me that, okay, yes, I still have a tremor, but my voice is stronger. I am heard more easily and I'm happy. And that's fine. If they're not, then very small doses of Botox can be useful. I found, I don't know if Dr. Johns and Dr. Sataloff have found this, but when they have generalized tremor of not only the vocal folds, but the pharynx, the constrictors, in those cases, I tend to find that botulinum toxin is maybe a little bit less effective when they have this very generalized upper pharyngeal tremor that seems to be accompanying the vocal tremor. So in those patients, I'm even more cautious. But generally, I want to go after the hypophonia first and try some strategies with voice therapy. And I will use very small doses of botulinum toxin as a trial to see if, exactly as Dr. John said, we can improve fluency.
Well, I mean, we're past our time, but this has been a wonderful discussion. I don't see any questions in the chat box, but if you have last minute thoughts, please go ahead and write it there. Otherwise, I think it's time for thank you, everyone. This has been a wonderful discussion. Thank you, everyone, for their time and for joining us. We hope to see you in, we have this quarterly other ASGO meetings. Please join us. Any last minute thoughts from anyone that they would like to add? Yes, please. James, there's a question. There you go. Okay, there we go.
Well, I want to say thank you, Dr. Tulunay, for putting this together. And on behalf of the American Society of Geriatric Otolaryngology, thanks for attending. I am the current president, and we hope to continue our good work by partnering with our allied organizations in otolaryngology and our related disciplines to continue to keep geriatric issues at the forefront of our minds as they span everything that we do in our changing society. So thank you so much.
And I echo the thanks to Ozlem for putting this all together, and to the fellow panelists. It's always fun working with you all.
Thank you so much. And yes, our current president, Mike Johns, he's definitely is moving us forward and in a wonderful manner. And I want to thank Alex, who's definitely worked very hard on getting all this together. It's a wonderful job. Thank you. And thank you for all the panelists for joining us, as well as the audience. We look forward to seeing you.
Are we able to get to this question from James Martin?
I don't know if it's...
I can't find it in the chat.
No, it's not in the chat. Maybe Alex can help.
Otherwise, if you email us the question, we'll be happy to disagree on the answer.
Take care, folks.
Thank you, everyone.
Bye.
Thank you, Ozlem.
Thanks all so much.
Thank you for having us. Bye-bye.